So the TB skin test, the PPD test, we talked about that. I showed you a picture of that a little bit. Which type of hypersensitivity reaction is it associated with?
Four.
Four? Everybody says four.
Are we gonna have answers on the tests that aren't for real, like
No, this is just a kind of, yeah, I wouldn't, well, maybe, I don't know. We'll see, right?
I guess we will.
You're gonna be fine, but we try to mimic the questions like the pants. Obviously, you haven't had a lot of courses yet to kind of go that deep. But as you get into the junior and senior semester, they're gonna mimic the pants because the pants is they can get very interesting when they ask you a type of question. Right? They want to know if you can figure out the best answer, because there may be multiple correct answers, but based off the scenario, what do you think is the best answer? So, fair? You're gonna be fine. Last week. Yep, so type 4 is what? Here it is. So type 4 is the hypersensitivity reaction associated with this, and if you remember, type 4 is where there's no antibodies involved, right? We have the helper T cells that come, they see the antigen, they get activated, and that first exposure to that antigen, you're not really going to have much that happens. On that second exposure, that's where you get that 48-hour, 72-hour delay, and that's where you start seeing that reaction. And I'll show you here, we talked about not only is the PPD test a test for that, but also too, if you ever touch some type of like poison oak, poison ivy, if you've ever been exposed to it in the past, the next time you're exposed to it, you're going to start to get those vesicles, those blisters that happen a few days afterwards. Cool? All right, so for blood type, so we got a patient who's B negative. Based off the choices you have down below, what is the best combination of packed red blood cells? So remember, those just have the red blood cells in them, there's nothing else, and the fresh frozen plasma for this patient. I saw one choice for C. See some head nods? See? Okay. So right, so for this patient, if we had to give packed red blood cells and fresh frozen plasma, the best choice is O negative and B negative, right? Now, take a look at the other answer choices. So if we needed to, if we needed to give O neg, that would be appropriate, right? Packed red blood cells. But if we needed to give fresh frozen plasma, that wouldn't be appropriate because those have anti-A and anti-B in them. So if we gave fresh frozen plasma to this patient, those antibodies that are in the fresh frozen plasma would attack that patient's RBCs, right? I didn't talk about this yesterday, but I want you to be aware of it. And if it's not, it wasn't in your slides, right? So take that for what it is. But when we talk about fresh frozen plasma, we don't really care about the RH factor in that plasma. So we could give a B negative patient B positive fresh frozen plasma because when they process that plasma for donation, there's going to be either very minimal to no red blood cells in there. And you need a certain amount of that antigen to actually stimulate this type of antibody response. So just be aware that if you are ever having to give fresh frozen plasma to somebody, the RH factor doesn't really matter because in that plasma, you're not going to have many, if any, RBCs. And if you have some, it's going to be so minimal that it's not going to create that antibody response in your patient. Make sense? All right, and then we talked about C, that's the best choice. For D, obviously, if they're B negative and we need to give packed red blood cells, we can give B negative red blood cells. If we gave A plasma, then that's going to have the anti-B in it, so if we gave that, that would attack our patient. And then obviously AB, we don't want to We don't want to give that because our patient has anti-A, and if we give O plasma that has anti-A and anti-B in it, and it will attack our patient's red blood cells. Cool? Questions about that? All right. Okay, so today we're going to be talking about neoplasia and cancer. I think this is a pretty interesting lecture because probably most of you have been involved with somebody who's ever had cancer, right? And definitely as a PA, you're gonna have patients who develop cancer. So kind of knowing that baseline about cancer can be helpful in treating our patients, but more so trying to prevent cancer in our patients. And one of the main ways we can do that as PAs is there are guidelines out there that tell us kind of when to screen for certain types of cancers. And if we actually follow those guidelines, I'm telling you, you have the ability to hopefully catch cancer early or prevent it. But when we talk about cancer, we're going to talk about just different terminology as it relates to that. We're going to talk about neoplasia and what's benign neoplasia, so what's not cancer when we think about cancer, and what's malignancy. We're going to talk about tumor staging and grading, different types of markers that we can use to help identify cancer, what causes cancer, and then some epidemiology on cancer. So with cancer, or with neoplasia, all that means is new growth. So you can have neoplasia, and it doesn't necessarily mean that it's cancer, right? Now there are different types of neoplasia. We have benign and we have malignant. And when it comes to the naming of these neoplasia, most of the time, if the word ends in oma, it means it's a benign neoplasia, a benign growth, right? That's not always the case, but for most of the time, that's what that means. Now, the exceptions to that. So melanoma, I think you probably all heard of that. It's a type of skin cancer, very aggressive skin cancer. If you ever get skin cancer, that's the one you don't want to get, because that thing, if you don't catch it in time, it can definitely metastasize and cause issues elsewhere and kill our patients. Lymphoma, we kind of talked on it a little bit. That's a blood cancer of our lymph cells, lymphocytes. And then leukemia, that's a different type of white blood cell cancer that we won't really get into, because you'll have hematology, oncology, your senior semester, and they're going to go into all those types of cancer, because there's quite a bit with that. And then with malignancy, most of the time those cancers are going to either have carcinoma in the name or sarcoma. And so when we think about those, typically carcinoma, those are going to be like our GI tract or our skin. And then sarcoma, these are our connective tissues, like our bones, our blood, and some of that fat that we'll talk about here shortly. So benign versus malignant. So benign cells, when you have a benign neoplasia, benign growth, they tend to stay localized. They don't spread. They don't develop those characteristics that actually allow it to get into our blood, our lymph vessels, and spread elsewhere. And the good thing about benign neoplasia is that they typically grow very slowly. They typically grow slowly, and when they grow slowly, it's actually good for us, because whenever we have tissues that grow slowly in our body, what our body likes to do is encapsulate it around this fibrous kind of mesh. And that's helpful that when we go and we evaluate some type of growth on our patient, that fibrous tissue around it helps us delineate whether it's benign or malignant. Let's see. Malignant cells, these guys, they rapidly spread. They like to get into the blood, they like to get into our lymph vessels, and they like to go elsewhere. And the problem with our malignant cells is that when they invade, they start to destroy our other tissues that they surround. They grow pretty fast, but the thing with these is, you guys remember when I talked about differentiated and undifferentiated cells? So our malignant cells, they can have this kind of wide range in differentiation. So if they're highly undifferentiated, if if they don't resemble that typical cell that it came from, those tend to grow a lot faster. And when they grow faster, they have a greater chance of spreading faster. So it's hard for us to catch those. If they are more differentiated, they can still grow pretty fast, but not as fast as the undifferentiated cells. And that gives us time to actually catch it, hopefully in time, and treat that patient before it starts to spread elsewhere. Now, neoplasia is another term for an undifferentiated cell, but what that means is that it dramatically looks unlike the cells that it comes from. So that's what neoplasia is, and I'll show you a picture of that here in a second. But if you get a report, if you take a biopsy of something and it says, neoplasia cells in whatever tissue you biopsy, that's a hallmarker that tells you that this is a bad type of cancer. This is a malignancy that has potential to spread elsewhere. So looking at this example here, so a lipoma, all that is just a tumor of our fat cells. A lot of patients are going to present with lipomas. These are benign tumors, right? But when you look at the lipoma, when you look at that benign tumor, if you look at letter A there, if you were to take a biopsy of normal fat cells, they would look very similar to this. They would look exactly the same, essentially. So, but when you look at letter B, these are what we call liposarcoma. This is a malignancy of fat cells. And look at the difference between them. So, picture A, it's kind of a light purple. You can see the borders of the cell. The cells are about the same size when you compare each other to them. But B, look how kind of disorganized that looks. There's multiple shapes in that picture there. Also, too, note that look at the staining. Look how much darker it is when you compare it to A. We call that hyperchromic. So whenever there's a malignancy, typically when they go and they stain these, the pathology will stain these, they're going to appear a lot darker. And that's because that cell is replicating faster, and so there's increased what we call mitotic activity. So that DNA is changing rapidly, and so that DNA is going to take up that staining a lot more so than the picture A will. So that's another feature of a malignant cell. But that B, when we see things like B, we call that pleomorphic, and that just means that the cells don't look the same, they're multi-shaped, and they have different sizes. And then another example for you, so we're looking at normal squamous cells versus neoplasia cells. If you look at kind of that big picture there, right, we got this kind of lighter purplish color, and then when we go to our neoplasia, it's a lot darker. It's taking up more of that staining. And then also too, when you kind of zoom down in it and look at that picture on the right-hand side, look how much different that looks. So at the bottom of the normal tissue, we see our normal basal cells down there. They're all flat and kind of, but there's a bunch of nuclei, and that's how it's supposed to be. And then as it kind of goes up into that normal tissue, those nuclei start to go away because that skin cells start to replicate. They start to die, right? We got dead skin cells up there, so they lose their nuclei. As opposed to the neoplasia, if you look at that basal layer, at that bottom layer, you see all those nuclei, but then at the very top, you still see those nuclei, right? That thing is rapidly proliferating, and so as a result, it's pushing up all those immature cells. And then also, too, it's a lot darker, right? So that's how we can kind of determine if we take a biopsy of tissue, whether or not it's normal tissue or whether it's a malignancy type of tissue. All right, so when we we talked about looking at tissue under the microscope, but now we're going to talk about how they kind of behave in the body. So as I kind of mentioned, benign tumors, they grow slowly, they're expansive. They grow slowly, and what they can do if they start to grow into an area that's contained, they can cause something called mass effect, where they start compressing that tissue. And when it does that, again, the body starts to try to encapsulate it around this fibrous capsule. So when we go and we evaluate this tissue, whatever it may be, so typically it's going to be on the surface. When we push on it, it's not going to be stuck to the patient. It's going to be mobile because it's not growing into the actual patient's tissue itself, because it creates this wall around it. So that's a characteristic of a benign tumor. As opposed to malignant tumors, these guys grow rapidly. Because they grow so rapidly, our body doesn't have time to actually encapsulate it. So when we go and we actually try to touch this tissue, it's going to be hard to appreciate kind of where it starts and stops because it's growing into the tissue that it's coming from. And I'll give you an example. When I was in phase 2, I remember I did a rotation in radiology, and a patient came in and she had breast cancer. They already knew she had breast cancer, and the radiologist said, hey, you know, we're going to be doing this procedure on this patient. I want you to go in there and I want you to feel this patient's breast cancer, just so you know what it feels like. That way, if you ever see it in the future, you'll have an idea, right? Patient was cool with it. She let me do it, but when I went to go palpate the mass on her breast, I felt something firm. I felt it was pretty firm, but I couldn't figure out like where it started and stopped. It felt like it just kind of invaded the tissue, and that's what these things do. And so keep that in mind if you ever see a patient and they come with like some type of growth or mass. If you can feel where it starts and stops, when it's wiggling and mobile, great, right? Probably benign. You don't know for sure, but most likely it's benign. If you touch a tissue and you can't feel where it begins and ends, that's concerning. That's concerning, and you got to make sure that you work it up. And remember, I talked about a few lectures back that we got metaplasia, dysplasia, and then that irreversible form, that malignant neoplasia. Once it gets to this stage, there's no going back. It's not going to revert back to normal tissue, so we need to treat that appropriately. All right, so here's an example of what I'm talking about. So we got a picture of a thyroid here, and it has both a benign and malignant neoplasia. The benign tissue, look, you see how it's encapsulated. If you were to go and press on that and touch on that, you'd be able to kind of, again, feel where it starts and ends. It's going to be mobile. As opposed to that malignant tissue, that thing is spreading its tentacles out, right? It's starting to invade that tissue. If you were to press on that or touch it or try to push on it, you may feel something firm there, but you're not going to be able to really appreciate the diameter of that neoplasia. And also, too, when it starts to invade, when it starts to go into tissue, that's where it starts to potentially have that impact to where it can metastasize, where it can get to our lymphatic vessels, where it gets to our blood vessels and go elsewhere in our body. So we want to try to catch it before it does that, because once it does that, it's going to be a lot harder to treat that. So metastasis, so all that means is that you have a malignant neoplasia. It started somewhere, and then it went elsewhere. It got to our bloodstream, it got to our blood vessels, and it went somewhere else in the body. Now, the thing about malignant cells is that they take time to develop that ability to actually metastasize. So you may have a malignant cell, and as it proliferates, it's going to start developing these adaptions to where, as those cells proliferate, they're starting to develop this ability to actually penetrate either a vessel wall and actually get into our bloodstream or our lymphatic vessels. So not all cancer cells have that ability, but the longer it sits there, the longer it develops that ability to actually invade our tissues and invade our blood and go elsewhere. Benign cells, they never metastasize. So again, if we have a benign tissue or benign neoplasia, and you're going to see this, and I'll also tell you this too. If you ever tell a patient they have a tumor or a neoplasia, oftentimes they're going to maybe have heard that word somewhere, so be very, very careful. If you ever use those terms and you think it's benign, make sure you tell them it's benign, because you don't want to cause this unnecessary worry. Because as soon as you throw out that word neoplasia or tumor, the patient's going to think, oh my God, I got cancer. But if you explain yourself and you explain the difference between benign and malignancy, hopefully you'll calm them down. But just be very, very careful when you use that word with our patients, because it can cause a lot of undue anxiety in our patients. So as it relates to metastasis, so there's several factors that can increase that risk of a malignant cell actually going elsewhere. So if it's growing quickly into our tissue, right? If it's growing quickly, if it's aggressive, then that's one factor that can potentially increase that risk of it going elsewhere. If you were to take a biopsy of it and it's undifferentiated, right? It has those immature, kind of premature features, that's another risk of it spreading rapidly. If it's growing quickly, obviously, if it's growing quickly, that kind of makes sense because it has more of an opportunity to actually get into areas where it can actually spread and go elsewhere. And then if it's bigger, all that means is that that cell is growing pretty quickly, and maybe it's developing those cells that have that ability to actually break away and metastasize. And there's 3 ways that typically cancer cells spread. And I kind of already alluded to them briefly, but in our blood. So it can go into our bloodstream, and once it gets to our blood, it's a free ride to wherever our blood starts to flow. So we call that hematogenous spread. Our lymphatic vessels, so around our blood vessels, we have lymph vessels that helps get rid of excess fluid that kind of builds up in our tissues. But if the cancer cell breaks free and goes to our lymphatic vessels, that's another way it can spread and can go elsewhere. And the last one is direct seeding of our body cavities. So typically it's going to be in our abdomen. If you have cancer in your abdomen somewhere, maybe on your colon or on your ovary, that cancer cell can break away, float within that abdominal cavity, and start implanting elsewhere. I'll show you a picture of that here shortly. So hematogenous spread. So most of the time when cancer spreads via the blood, it's going to spread via the veins because our veins, they don't have as much muscle surrounding them as would an artery. So when a cancer cell gets near our blood vessel, our veins, it can actually penetrate that vein wall, go for that ride, and typically, if it does that, it's going to end up in 2 places, either the liver or the lungs. And think about our liver and our lungs. These are essentially filters for our body, right? And as that blood starts to get into our liver or lungs, it starts to slow down so it can do its thing in those tissues. And when that blood slows down, that allows that that cancer to escape our blood and either invade our liver or go to our lungs. And think about the liver too. The liver, it has a lot of nutrients in there, right? That's where our body absorbs gets most of our nutrients from our GI tract. And so cancer loves to hang out there because that's where it's going to get all those nutrients to help it assist it to grow. Our lymphatic vessels, so like I said, we have lymphatic vessels that surround our blood vessels, and that flow within the lymphatic vessels it's very slow. It's very, very slow. So if a cancer actually breaks into there, it's going to travel that lymphatic vessel, and typically it's going to end up in the lymph node, right? So that's why I told you guys yesterday, you have a patient that comes in, and they have this lymph node that's been slowly growing, and it's not painful. It may be that you had a cancer cell that escaped from wherever it started at, got to that lymph vessel, and started to set up shop there. Now, we have something called a sentinel lymph node. And all that means is that it's the first lymph node that drains the tissue to wherever that cancer is. So very commonly, when we talk about breast cancer, we talk about the sentinel lymph node. Because if we have a breast cancer, if we have type of mass in our breast tissue, you have lymphatic vessels that surround our breast tissue, right? And when a patient develops breast cancer, one of the things that they'll do is they will try to find that first lymph node, because if they see that a cancer has spread into that first lymph node, that kind of delineates how they're going to treat this. And the way they do this typically is that they'll inject the area around the breast cancer with this dye, this blue dye. They also inject this kind of radioactive tracer. So they inject it, and then they find that first lymph node when they're taking out that tumor. They find that first lymph node, and the first lymph node that turns blue, and they also use that tracer to help find that lymph node. They'll biopsy, they'll remove it from that patient, and they'll send it to pathology. And while they're in surgery, they're going to check to see if there's any breast cancer cells in there. If there are, they're going to remove it, and they're going to look at the next lymph node. If that has cancer in there, they're probably going to remove all those lymph nodes in that axillary region, because now they don't know how far this cancer has spread. The problem is that when they do that, when you take away your lymph nodes, think about the lymph nodes and lymph vessels. They help drain that excess fluid. So when you strip that whole area of the lymphatic vessels and lymph nodes, now you have no way of removing that excess fluid that builds up in our arms. So if you've ever seen somebody with breast cancer, if they've had to remove all those lymph nodes, they typically have to wear like a compression band, because if they use their arm too much, it's gonna start to swell up and blow up, and then it's gonna impact their ability to use it. And so we really try, if we can, to capture this sooner. That way we can not, one, get rid of that cancer, but two, try to prevent negative outcomes that can occur if we have to treat this more aggressively by removing all those lymph nodes. All right, so direct seeding. So again, this picture here is an example of somebody who has ovarian cancer. And you see in that big green circle, that's where that cancer initially started, right? And then for some reason, those cancer cells, they break away, they break free, and they start to float in the abdomen, and they can actually implant on other tissues within the abdomen. So here it implanted on the peritoneum, and if you see closely, you got that big blue arrow that shows you one of those ovarian cancer, where it kind of set up shop. But if you look at it real closely, you can see other little small cancer cells that have implanted on that peritoneum. And so when that happens, again, this is a form of metastasis. Now, one thing I want you to be aware of, in order for us to call a cancer metastatic, it has to start somewhere and it has to go somewhere else. If it locally grows, if it's invading nearby structures, but it hasn't, so for example here, if the ovarian cancer was growing so much that it started to grow into the colon, that wouldn't be metastasis. That's called local invasion. So for this to actually be called metastasis, it has to either start and then leave that tissue and go elsewhere. Make sense? Okay. So this table here is just a chart that you can use to kind of help you in your studies. It juxtaposes the difference between benign and malignant tissues and cells. It's the same way here. We've talked about most of this already, so when you're studying, hopefully this helps just kind of delineate what is what. All right, so tumor staging and grading. So this we don't do too much tumor staging and grading, especially grading in primary care. But you may get a report back on one of your patients who has cancer, and if you're able to read that report and understand it, kind of helps you, gives you an idea of the prognosis for our patient. So when they do staging, this was what tells us the likelihood that this patient's, the likelihood that, essentially how long this patient's gonna live, right? The percentage, the what's the word I'm looking for? The 5-year survival rate. And every cancer has a different type of 5-year survival rate, and it's all based on this TNM system. And whenever they're staging the cancer, they want to use that primary tumor. So if you have metastasis, they don't want to use that one. They want to try to find out where that primary tumor started and use that as the basis for coming up with that staging of that cancer. And there's different ways of doing it, and there's not just a one way to do this. They use biopsies, they use imaging on our patients, they'll go in and do surgery, and they'll use all that information that they develop to actually come up with the stage of our patient. And the most common staging technique that they use is called the TNM system. There are other systems out there, but by far the most common is the TNM system. So the first one, T, right, they're gonna look at that primary tumor size. They're gonna see how big it is. And based off how big it is, they're gonna give it a number. I'll show you what that looks like here in a second. Then they're gonna look at the lymph nodes, and they're gonna see, okay, are there any lymph nodes involved in this cancer, and if so, how many? And based off that, they're gonna give that a number. And the last one is metastasis. Is there any evidence that this cancer has gone elsewhere? And then if they find that, they're gonna give that a number. And they're gonna use all those numbers to give it a stage of cancer. So stage 1, stage 2, stage 3, stage 4, right? But the thing about the TNM system is that every cancer has their own TNM system. So if you have a cancer that is T1 because it's, 3 centimeters, right? That doesn't mean that all cancer cells that are 3 centimeters are T1. It's based off that specific cancer, and there's a bunch of guidelines out there that tell us that. So the main reason why I'm bringing this up is because I want you just to understand that this is how they determine that. But as far as specific cancer, you're gonna have to look at this chart if you ever have to, and and then based off that cancer, determine, okay, what does this qualify as? Again, most of the time, we're not doing that in primary care. We're getting a report back, and we're just trying to interpret and understand it for our patients. That's how they do that. Okay, so this is the kind of blueprint, the baseline for what they use though. So if a patient, if we're looking at the T, the tumor size, right? If they're not able to assess it for whatever reason, maybe they haven't done the imaging yet, or maybe they haven't done a biopsy of the tissue, well then they're gonna call that TX because they don't have enough information. If they go and they try to evaluate this thing that they think is growing or they think is there, but it's not there, then they'll use T0. Now most of the time we don't really use that, but they had to have something just in case that happened. But if you have a patient who's being worked up for a tumor, they actually saw something, you felt something, they're gonna give it a number. So TIS, that means carcinoma in situ. And all that means is that when they went and they evaluated this lesion that's growing, that cancer was localized. It hasn't spread anywhere. It hasn't crossed that point of no return to where it can actually go out to our bloodstream. And typically they'll do that via biopsy. They're looking under the microscope and they're going to say, okay, how much has this tumor grown? Is it past a certain point in that tissue that we took it from? And if it's carcinoma in situ, that's great, because that means we can easily treat this. We can cut this out and get rid of it, and the patient's good to go. And then T1 through T4, that just varies based off the size of the tumor or the depth of invasion that it's growing into. So obviously the higher the number, either the more it's grown into that tissue or the bigger that tumor is. Okay? And then we go into our N, those are our lymph nodes. So same thing, NX, you're not able to assess it. N0, when they actually took that tissue, that lymph node tissue, and looked at it under the microscope, cut it into pieces and looked for cancer cells, they didn't find any malignancy or no type of cancer cells, so that's good. And then N1 through N3, that means that they found cancer cells in those lymph nodes, but it doesn't necessarily mean, like if you're in N1, it doesn't mean that they only found one lymph node. Again, it's based off the cancer. So if you have, it's based off the cancer, and if you have 2 or 3, that could be an N1 or it could be an N2, depending on what cancer you're dealing with, okay? And then M is pretty easy, right? Either they found evidence of metastasis or they didn't. If they didn't, it's an M0, and if they did, then that means it's an M1. And typically, if you have metastasis, it's gonna push you automatically to grade 4, or stage 4. And so if you see any evidence of metastasis, that normally means that, okay, this patient's stage 4, and now that's going to determine how we're going to approach our treatment for this patient. So this is an example of colon cancer. And if you look at it, they use all those T&M systems to determine, okay, what stage is this cancer? And so if this patient had, but for colon cancer, it's not so much the size of the tumor, it's the depth of invasion. And again, every cancer is a little bit different, but essentially it's the same thing. How big is this primary tumor? So if for example, if it grew into the subserosa, but they found no lymph nodes, and didn't metastasize, then that's a stage 2. Versus if stage 4, any T, any N, but if there was any evidence of metastasis, automatically that's a stage 4 cancer. Now, there is something called the Duke's criteria. Don't worry about that. They don't use that anymore. This is kind of an older slide, but they used to use a different type of cancer staging called the Duke's to predict the survivability of our patients. We don't really use that anymore. They've transitioned to the T&M system. And this is that example of what I just showed you. So actual picture. So stage 0. That cancer is local, it hasn't metastasized, we can easily cut that out. Versus stage 4, that cancer has metastasized, it's gone elsewhere in the body, and so that predicts our survivability for our patient. Okay, now grading, a lot of people kind of get staging and grading confused. Again, the stage of the cancer just kind of predicts the prognosis for our patient. The grading is typically used by our oncologists. Our oncologists are going to use grading to determine the best treatment for our patient. And what they do is that they'll take these cancer cells they'll look at them under the microscope, and they're going to see how undifferentiated they are. And if they're very undifferentiated, that means that it's bad. It's really bad because it's more aggressive. It has a greater chance of spreading throughout their body. But based off their ability to grade these tumor cells, that's going to let the oncologist know, okay, this cancer is very aggressive, so I'm going to treat it this way. Or this cancer is well differentiated, it's still cancer, but because it looks like this, I can use this method to actually treat it. So again, this is mostly used by our oncology folks, but again, you might get a report back, you're the PCF for a patient who has cancer, you refer them off to an oncologist, you're going to be getting their notes back because you have to follow these patients. You still need to be aware of what's going on there. So if you understand the grading, then you're able to kind of get an idea of how best we're going to be able to treat this patient. But the oncology folks, they're going to be driving this. They're going to be actually prescribing these medications to treat your patients. All right, tumor markers. So tumor markers. There are a lot of tumor markers out there. There are some that mostly found in blood. That's what we're mostly going to use. But there are some in our stool and our urine as well, and in actual tissues. There are actual tumor markers there. And the thing with tumor markers is if you think about cancer cells, I told you that most of the time they start to revert back to an undifferentiated type of look, right? When we talk about undifferentiated, I think the first lecture I gave, when you think about tumor cells, they revert back to their old ways. And so they, as a result, they start to release these chemicals that are typically found when a child is developing a fetus, or when they're a fetus, right? Now, by the time that baby is delivered, those immature fetal cells, they start to mature a little bit more. And so if you were to draw a child's blood, they shouldn't have many of these fetal markers. But if a cancer cell is reverting back to its old ways when it was in the fetus because it's undifferentiated, well, then they're going to start to release these molecules that typically you would find in a developing fetus. Okay? And we can use tumor markers to either support that diagnosis of a cancer, especially if you're not entirely sure. We most of the time use it to assess the response to our treatment of cancer. So if we have a tumor marker that our patient has cancer, and then we go and treat this patient with cancer, those tumor markers should start to decline as we start to destroy those cancer cells. And then one of the other things that we'll do is that we'll use our tumor markers to actually monitor our patients who are in remission. So patient, we treated them for cancer, we cured them, so to speak, and then periodically we're going to draw their blood. It's typically oncology who's doing this. Periodically they'll draw their blood to look for those tumor markers. If they see them coming back, okay, what's going on here? Why are we seeing X tumor marker? This shouldn't be happening because we destroyed their cancer. And that can kind of key us in to say, okay, we need to go back in and figure out what's going on here. Did this patient have a return of the cancer they had previously? So there are all kinds of tumor markers out there. And look at the names of some of these. We got alpha fetoprotein, right? We talked about how they revert back to kind of a premature fetal state. So we name these based off the things we identify whenever we take that sample and look at it in the lab. We got carcinoembryonic antigen. Again, another type of fetal molecule that's produced whenever the fetus is developing. But as we mature, as we get older, we shouldn't be having too much of these. Human chorionic gonadotropin, typically HCG, that's the test that we normally do whenever we are checking for pregnancy in a female, right? But testicular cells can actually produce this if they start reverting to cancer. And think about kind of the origin, when we're in the fetus and we're first developing, we got our ovaries, we got our testicles, right? Well, we all start off as essentially one thing. And then based off our, what genes we receive, right? We got the X or the Y chromosome. That's going to delineate where we separate out. So initially we start off as essentially the same thing. And as we spread out, as we start to develop our male and female characteristics, then we're going to develop our testicles or our ovaries. But the testicles, because they started out initially as the same thing as ovaries, we're going to have these substances that if they revert back to their old ways, and we're gonna start seeing them in their blood. So most of the time, you're not gonna see, I mean, you shouldn't see any HCG in a male, except if they have testicular cancer, then those cells revert back, and they start releasing those cells or those molecules that we shouldn't be. Now, I will say that you gotta be very, very careful if you're gonna be ordering tumor markers on your patient. Be super careful, because we can have normal levels of tumor markers in our blood, right? And so if you think you have a patient who has some type of malignancy, and you order a tumor marker, how do you know, and you have no other evidence, how do you know that that tumor marker is actually due to cancer, or it's just a normal amount of marker that they have in their blood? And so if you do that, and you tell your patient, hey, I drew your blood for liver cancer markers, and it was positive, or it was a little bit elevated. Now, what did you just do to that patient? You created this, now this patient thinks, oh shoot, I got liver cancer. And now, what do you do with that? What are you gonna do with that? Are you going to just say, that's probably nothing, because how do you know now? You probably will send this patient off to a specialist, and that specialist will probably work this patient up. At the end of the day, if they work this patient up and there's no evidence of whatever cancer that you checked for that tumor marker for, you just created this whole big worrisome scenario for your patient. So think about that. When you order tumor markers, if you ever do, have a very, very good reason why you do it. Because if you just kind of willy-nilly do it, you're going to be stuck, probably, and it's going to cause a lot of anxiety in our patients. But the one tumor marker that I think you can, and it'd be justifiable to order, is the PSA. That PSA test is so specific for prostate cancer, it's actually a recommended guideline that we check PSAs on our patients, that if you have a patient and you are screening for prostate cancer, or you think this patient has prostate cancer, then definitely do it. That's the only one that you should comfortably, I think, order if you're looking for prostate cancer. Now, prostate cancer, or the PSA, yes, we associate it with prostate cancer, and it definitely can be high with prostate cancer, but there are some other things that can cause an elevated PSA level, and you'll learn about this in your urology. But most of the time when you're ordering a PSA on a patient, you have to do something called shared decision making, where you explain to your patient, hey, you're at that age where I think we should start checking your prostate. There's a blood test called a PSA. It could be a marker for prostate cancer, but also too, men, as we get older, it's natural, what's gonna happen, your prostate starts to enlarge. And so if you have something called benign prostatic hyperplasia, that can also cause our PSA to be elevated. So if you have a PSA is elevated, and you're not quite sure if it's prostate cancer or BPH, you're gonna have to send that patient for a workup. And typically what they're gonna do is they'll probably do a transrectal ultrasound, where they take an ultrasound, put it through the rectum, and they look at the prostate that way. They'll probably do a biopsy of different parts of the prostate. That opens up that patient to pain, right? It opens that patient up to potential infection. And so whenever you're doing any type of tumor marker testing, especially for that PSA, it's one of those things that you just don't do, because if you get that elevated level, now that patient, it blocked them and took it to urology, and some patients don't want to know. They don't want to know, they don't care, they don't want to go through all that potential unnecessary the complications that develop. So that's why you talk to your patient about that. There are a ton of other tumor markers. Again, you don't have to memorize any of this, but just understand that there's a lot out there that we can potentially use to help us diagnose cancer, but there's quite a bit. Okay, we're kind of moving a little quickly, so let's go ahead and take a break until 9 o'clock. For example,
You guys are actually what happened? Yeah, yeah. So, dude. Meiosis. Like it's the circular. And then it's the yeah, but you should also get the radial and then the circular. Cartoons like circular.
I was actually like I'm not a fan of the whole. I'm not a fan of eating it as a like I'm for like science like shit like that. Yeah, like I've only like a couple times ever eaten something like get really heavy a day or something just testing like yesterday I mean that's like my wife made like look great salad.
I mean, and also like
Like a pasta salad. Kim dirty.
I love cake. I do. Some lights, they taste different.
Yeah.
But I rather do like a light that tastes good. And like their ranch, their seasoning.
The wish one is good. Like the ketchup, like calories in the bag. Or the what you call it? The wish one's good.
I used to do my favorite one ranch.
I always get like
yeah.
I love her making like the French.
I usually just do like so I'll just buy off that. Usually put in rice. Yeah, you get like cucumber, like cherry tomatoes, maybe some fancy olives.
Those are like. Say it. It's like a soccer match. I just, it's a nice SUV. It's a nice SUV.
So be careful about 24s because that's when you're going to train. That's like when they yeah, there's a lot
I want something that looks decent. I was looking at what I was looking at, and I was like, I never do. I knew it was apartments. Do you agree? Like whenever like my mom says, I'm like, I don't know. Because there's somebody yeah, but do you agree with this?
Yeah, that's fine. I'm like,
How do they find
yeah, same thing. I thought I heard but that's another thing though, is like I also want a car that's because I think it was a lot of material. I don't want well, not there's a thing that's
yeah. What's your no, $40. I never buy used cars. Let's see what you buy.
Alright guys, you guys ready to get back to it? Alright. So, when it comes to cancer, right, there are a lot of reasons, there are a lot of things that can cause it. A number of things. Chemicals, different types of viruses, but the problem is that even though we know some things that cause cancer, there are a lot of things that we don't know about cancer. If we did, we'd have a cure for cancer, we wouldn't have cancer, right? So chemicals. So probably one of the most common things you've heard of is asbestos, right? We used to use this quite a bit, not so much anymore. They still use it in some places, but we used to use it quite a bit when they were constructing buildings. So this building here only has asbestos in it. Now asbestos is fine, right? As long as it stays where it's supposed to stay and doesn't get into the air, it's fine. But when we start messing with asbestos and starts getting into the air, we can actually breathe it in. And when we breathe it in, it gets to our lungs and causes cancer of our pleural lining. We call that mesothelioma. So you've heard of those, you've had them. Exactly. And so that's why they know this. They know that this is so much associated with mesothelioma that they're probably going to win that case. But again, as long as you leave it alone, it's not going to do anything. But when you start messing with the insides of buildings and you start releasing that stuff into the air, that's where you have that risk of developing that mesothelioma. Microorganisms, H. pylori. So a lot of people have H. pylori. I bet some of you in this class have it as well, right? Half of the world has H. pylori, and it may not cause any issues. And when we think about H. pylori, we typically think about peptic ulcers. Well, we can have chronic inflammation because H. pylori is causing gastric irritation. That H. pylori can predispose you to developing gastric cancer, adenocarcinoma. And so, even though a lot of the world has it, if you got a patient who has it, for whatever reason you test them and they have it, you want to treat that because one, you'll hopefully get rid of their GI symptoms, hopefully. Two, if you don't, then maybe you're going to be at greater risk of developing some type of gastric cancer. DNA, so different viruses. So HPV, there's a ton of HPV viruses out there. You guys learn about that, micro? Yeah, there's a ton of them out there. But there are certain ones that can predispose us to developing cervical cancer in our females and actually penile cancer in our males. So that's why we push, regardless of, that's why we push that vaccine so hard, because if we can give that body the ability to fight off the HPV infection, then hopefully one day we can eradicate cervical cancer. Penile cancer, you're not going to see that too much, but it still can happen. But hopefully we can eradicate cervical cancer. Not only that, that can also cause cancer of our throat as well. And so if we're able to get rid of that by protecting our body, by giving us that vaccine, then maybe one day we'll get rid of HPV virus altogether. Not get rid of it, but reduce our risk of having cervical cancer and throat cancer. UV light radiation, so you've all heard of it, going out in the sun. If you're exposed to chronic sun exposure, that UV light radiation can actually start damaging our DNA and cause that DNA to mutate and predispose us to developing basal cell carcinoma, squamous cell carcinoma, melanoma. So that's why it's super important to wear sunscreen. Now, you probably heard like sunscreen is also potentially cancer causing. So I don't know, you can't win, right? But you still gotta recommend to your patients, you still should, because definitely for sure we know that sun can potentially cause cancer in our patients, and so we want to try to protect them by reducing that risk of that DNA being damaged. Ionizing radiation, so be very, very careful. I know you're taking radiology right now. Be very careful when you order imaging on your patient, especially CTs, because if you don't have a good reason for it, hopefully you do, but if you don't have a good reason for it, now you're exposing that patient to this ionizing radiation. And maybe right now, they're 20, they're 30, not a big deal. But you just exposed their cells to a very high dose of radiation. In 20, 30 years, did that radiation potentially increase their risk of developing whatever cancer you just blasted them with, right? Or whatever radiation you just blasted them with. So I've always been super careful when I've ordered CTs. I try not to order CTs unless I really, really need to. There are better imaging. In radiology, we'll get into this with you. There are some, maybe not better, but some other imagings you could do to help you kind of get to the same conclusion. But when we blast our cells with radiation, then you're potentially damaging that DNA. Then later in life, that DNA has accumulated to where it's so deformed and damaged that now it's producing cancer cells, and then now your patient develops whatever cancer 20, 30 years from down the line. But we can also use radiation, like I talked about previously, to treat cancer. So remember I told you those cancer cells, they're rapidly dividing, and that radiation likes to destroy those rapidly dividing cancer cells. It also affects our other cells that rapidly divide, so we can use that to our benefit. Typically when we're doing that though, it's a targeted approach. You can still get damage to other tissues, but that's the one benefit, that even though it causes cancer and potentially increases the risk of cancer, it's a way of treating cancer as well. All right, genetics. So this is an FYI slide, and this is an FYI slide because when you talk about genetics, this could be a whole other block in PA school, right? The main thing I want you to know is that certain people can be born with certain genes from their parents that increase their risk of causing a gene mutation in their cells that can increase their risk of developing cancer. There's different ways this happens, but the big thing is that if you're born with a some type of gene from your parent, and that puts you at a potential increased risk for cancer. Doesn't mean though you're going to get cancer. It doesn't mean that. But sometimes that's helpful, especially when we're trying to determine what do we do for our patients. And I'll give you a good example. The BRCA. You've heard of BRCA before? BRCA? Patients will come see you, and they'll say, hey, I've had a family history of breast cancer, or ovarian cancer, or pancreatic cancer. Typically it's breast cancer. And they'll say, I want to be tested for BRCA gene mutations. And so what are you going to do with that, right? Because if that result comes back and they have some type of mutation in their BRCA gene, does that mean that patient's going to get breast cancer? No, it doesn't mean that. But now this patient has information and they can make that decision based off what they want to do with that. Do they want to have a mastectomy, just remove their breasts altogether? Do they want to remove their ovaries? But it's one of those things that just because you have the gene doesn't necessarily mean you're going to get that cancer. But it can kind of get down a slippery slope. Most of the time when this happens, and I'll just for your awareness, if you ever do some type of genetic testing, you have to counsel them. There's this form that should be in your MTS where you counsel them on the risk of getting this genetic testing. And if it's positive or if it's abnormal, most of the time you're going to send them to an actual geneticist, and that's where they're going to sit down and have that deep conversation about what they're going to do with that, because it can kind of get a little sticky. All right, so epidemiology of cancer and then kind of ways it can present. So if you, this slide, this data is a little old. I was trying to find something recent. This was the best one that was out there that kind of showed that was the cleanest, I guess, to present. But so if you look at this slide here, you see that you can see that the death rates, overall death rates, they're going down, right? But if you look at the green graphs, the green bars, the cancer deaths are going up. So why do you think that is? Why do you think that's happening?
Getting better at treating it when people take cancer.
So getting better at treating it. Okay.
Just as you get older, your body's more prone to like developing those types of cells. Like your cells starts coming at.
Yeah, they start developing mutations, and it's harder to repair that DNA that's damaged. Yes, so those are really good answers. So, but think about this, right? Back in the day, people used to die from what? Old age. People used to die from old age because back then, we didn't have very good screening techniques, we didn't have very good imaging techniques. And so when people died from old age, did they really die from old age? Did they die from cancer? Now we have so many guidelines out there that help us, that tell us when to screen for cancer. We have better techniques, we have better labs, that we're actually finding cancer more so than we did back a long time ago. And so even though the death rates are going down, we're catching cancer sooner, we're diagnosing cancer accurately, and as a result, when somebody dies, they're not dying from old age anymore, they're dying from whatever cancer that we identified. So that kind of explains why cancer is going up, but the death rate is going down. But still, you're right though, I mean, as we get older, we have difficulty in our cells repairing our damaged DNA, so that might explain some of it as well. So this graph right here, this is 2025, and these are the projected new cancer cases to be expected in the United States. And so if you look at the male, we project over 300,000 cases of prostate cancer, and then for females, over 300,000 for breast cancer. And that makes sense because we have very good guidelines, we have very good screening techniques to check for prostate and breast cancer. We do mammograms in our ladies, we do digital rectal exams and PSA testing in our men. So of course, we're going to catch these more as opposed to the other one because these are kind of set in stone, have been reviewed and studied and said, okay, these are the cancers, this is how we're going to check for these cancers, and so we're going to catch more of these cases. It used to be that lung cancer was the top cause of new cases, but with our screening techniques that we have now, it's actually breast and prostate. But if you look at the next slide, this relates to cancer deaths. Even though prostate and breast are going to be the most common ones we're going to see, lung cancer is still the #1 cause of cancer-related death in the United States. Now we're getting better because there's a really big push to stop smoking. I know, or not smoke. I know you've heard it throughout growing up probably. But even so, people still smoke. Other things in the environment can predispose you to developing lung cancer. But the problem with lung cancer, and a lot of cancers really, is that some of these cancers, especially lung cancer, they don't present until it's too late. You don't start having symptoms until that cancer has already metastasized. So that's the difficulty with some of these cancers. Pancreatic cancer is another one. Pancreatic cancer, if you've ever known anybody with pancreatic cancer, by the time they find pancreatic cancer, most of the time, that thing has metastasized, and that type of cancer is so aggressive that most people die within a year. Crazy, hope you never have a patient with it, but if they do, it's very hard, very difficult to treat, and if they have it, most likely they're going to die within a year, maybe 2 if they're lucky. But that's the problem with some of these cancers, that they don't present, you don't know they have it until it's too late, until that cancer has already spread. And once it's spread, it's very hard to treat. So like one of you guys alluded to, so definitely though, age, as you get older, you are at greater risk of developing any type of cancer. And like you alluded to, that's because as we go through life, we're getting all this damage to our DNA. That DNA is going to make these abnormal proteins that cause our cells to start proliferating when it shouldn't. And also too, as we get older, our DNA repair mechanisms, they'll start to degrade. They don't work as well. So if we're developing all these mutations within our DNA, our repair mechanisms don't work well, then that's going to definitely predispose us to developing cancer as we get older and later in life. Genetics, like I kind of alluded to already, not all cancers are due to genetics, but if you do have a genetic predisposition, then maybe you have an increased risk of cancer, but it doesn't necessarily always mean that. But the environment is the biggest one. What we're exposed to in our environment, that's going to be the biggest risk factor for us to develop cancer. And this slide here says acquired conditions. So think back when I talked about Barrett's esophagus. Remember I talked about that? And how you get that metaplasia and then dysplasia. If you are exposed to something, so in our stomach, for example, we're exposed to this chronic acid that's going into our esophagus. It's that chronic irritation, it's that chronic inflammation that can damage those cells that potentially can transform those cells to cancer cells. And so it's things in our environment, things that we are chronically exposed to that offer that greatest risk for us developing cancer. So if we can somehow figure out what is stimulating our cells to become inflamed, and we can stop that, and we can potentially stop that metaplasia, that dysplasia, and hopefully prevent that malignant neoplasia, that transformation into cancer. So environmental risk factors, again, biggest one is smoking. I think you all know that. Whenever we screen our patients, whenever we talk to our patients, we ask them their social history, and smoking is one of those things. And if you can get your patient to stop smoking, you are potentially saving their life. Now you're going to have a hard time because some patients, they don't want to stop smoking, they don't care. They're not thinking about the future, they're thinking about how good that nicotine hit is at that moment. If we can stop smoking, if you can tell our patients the risks and really sit down and talk with them, maybe a few of them will bite, and then you can potentially decrease their risk of developing cancer. Alcohol use. So this is more so, alcohol in general is, it depends on how much you're drinking, obviously, but if you combine that with smoking, that creates a synergistic effect. So if you got a smoker who's drinking as well, especially if you're drinking heavily, that's going to greatly increase their risk of cancer, especially the GI tract, because that tobacco smoke, if you're smoking cigarettes, it's not just going to your lungs, you're getting that into your blood, it's going into your GI system. All those chemicals are damaging your cells. You throw in alcohol in that. When the alcohol metabolizes, it's also causing irritation and inflammation to your GI system. So these are big risk factors for developing GI cancers. Smoking, when we think about smoking, we think about lung cancer, obviously, but bladder cancer is a big one with smoking as well. So if somebody is a smoker, they're at greater risk for developing bladder cancer. Pancreatic cancer is another big one with smoking. So smoking in general, I know you guys know is bad, right? But think about our patients, and if we can hopefully talk them into stopping smoking, then maybe we can save their life later on, or at least reduce the potential of them developing cancer. There are definitely some other ones out there, but smoking and alcohol are the biggest ones. Okay, so when it comes to cancer, right, patients are going to present all kinds of ways, but probably one of the biggest things that should key you in that somebody maybe has cancer is if they have unintentional weight loss. If somebody comes in and they're telling you they're losing weight and they haven't changed anything, it's their diet, they haven't started exercising more, especially if they're older, that should key you into, okay, maybe the person has cancer. Maybe they have no other symptoms besides that. But unintentional weight loss is one of those red flags that if a patient presents to you and they report this, then that should key you into looking for some type of cancer. Now, a patient may not notice this. A patient may not be aware that they're losing weight. Hopefully, this patient's not new to you, and what you should be doing whenever you're seeing your patients is looking at their vital signs, right? And you can look back at a history of their vital signs, and you can see, they were 200 pounds 6 months ago, now they're 180, okay, is that too concerning? Maybe, maybe not, right? Talk to your patient and say, are you doing anything to lose weight? Are you trying to lose weight? Are you exercising more? If they say no, okay. Have you had any other symptoms, right? Just make that weight loss key weight that maybe something potentially bad is going on. If they come back again in another 3 months and they continue to drop that weight, okay, now it's time to really figure out what's going on, get that history from that patient, figure out if they're a smoker, if they're a drinker, see what's going on to try to identify if it's a cancerous process. When a person develops cancer though, there's something called cachexia. So these patients here, when they develop cancer and it's already kind of advanced and spread, maybe you've seen pictures, maybe you've dealt with somebody, a loved one who's maybe had this, but that cancer is going to essentially start to steal all these nutrients from that person's body. When that happens, these people are going to be very, very skinny, very, very sick, because those cancer cells, they're rapidly dividing, they're rapidly growing, rapidly trying to proliferate, and because of that, it needs a lot of nutrients. So it's stealing nutrients from our cells that, like our muscle cells, our fat cells, and so as a result, because that cancer is growing so quickly, everything else is going to start starving. And when it starts starving, they start to get this cachexic appearance, they start to get very skinny, and they look just very, very super, super sick. Typically, at that point, they're probably going to pass eventually. But that's a typical feature of somebody who's had far advanced cancer and those cells are just kind of being destroyed because they're not getting nutrients. There's also something called paraneoplastic syndromes. There's a ton of them out there. But this may be the first sign that your patient has cancer. What I mean by paraneoplastic is that you're doing whatever for a patient, you see a patient, for whatever reason, you order a lab test, right? And you get this kind of high calcium level. That could be the first sign that your patient has cancer. The patient's coming in because whatever, they're not having any symptoms of cancer, but then all of a sudden you do their blood for whatever reason, it could be a number of reasons, and you get this very high level of calcium. What are you going to do with that, right? Is it a lab error? Is it, do they have something wrong with their thyroid? Or is it cancer, parathyroid, or is it cancer? And so most of the time when this happens, there's a couple different reasons why this happens. But I want you guys to know that if you have a tumor that metastasizes to our bones, sometimes that can break down our bones and cause calcium to spill out to our blood, so you get this very high calcium level. There's other ways that we'll talk about when we get to the endo lecture, but this is one way. And then hypercoagulability, so a patient making blood clots, especially when they have no risk factors for making blood clots, that should also kick you off to thinking about cancer. Because what cancer cells do is that they'll release these molecules that will trigger that coagulation cascade and cause these blood clots in our blood that shouldn't be there. So when you think about blood clots forming, we'll talk about it in a few lectures from here. Most of the time, you have to have some type of either like venous stasis where the blood is not flowing, some type of trauma, or you're taking some type of medication that can increase that risk of blood clots forming. If a patient doesn't have any risk factors and they all of a sudden develop this blood clot in their lung or their legs, then maybe there's a cancer going on because those cancer cells are releasing these molecules that are triggering that coagulation cascade and cause this blood clot to form. So that's one of those other paraneoplastic syndromes that you have to be careful about. Here's some other ones. Again, there's more than this as well, but the ones I want you to be aware of are the hypercalcemia and the blood clots. All right. So when it comes to the location of the tumor, right? If you have a tumor that's growing, it really kind of depends on where it's at for it to manifest to you as a clinician to actually be aware that it's going on. So if you have a tumor in the brain, for example, and it's starting to push on tissues within the brain, well then, especially the pituitary gland, you got your optic chiasm, those nerves that run back and allow us to see. If you have a pituitary tumor and it's growing, it can actually push on that optic chiasm and then cause blindness, right? If it's pushing on, you got a tumor in the lung and it's pushing on that superior vena cava, sometimes you can get this swelling that develops because blood flow is not going back into the heart. Maybe you'll get JVD. If it's pushing on a blood vessel, then anything that blood vessel feeds, that tissue's going to die. So maybe you'll get some necrosis somewhere. And then also too, and this is definitely something that I've encountered, cancer cells can serve as like a collection point for infections to grow. So right when I graduated PA school, I went to Vandenberg Air Force Base, now Space Force Base, and they had a very small clinic there, and I had a I don't know how old, I think he was 60-something years old. He came in and he had symptoms of pneumonia. And he was coughing, he had fevers, all that sputum production. So I shot a chest x-ray on him and he had pneumonia. Okay, great. I treated him for the pneumonia, but I remembered this when I was here and I said, hey, I want you to come back. I think I told him 12 weeks. Let's go ahead and repeat this chest x-ray just to make sure, one, that the pneumonia has cleared, which it should have by then, and then just make sure you're better, right? So he comes back, I shoot the chest x-ray, and behind that pneumonia, which wasn't caught in that initial study, he had a mass on his lung. And he had lung cancer, right? So we were able to get him to a oncologist. I never saw him after that, so I don't know what happened to him, but because we were so small, once we didn't have the capability to treat him at that basis. If you've ever been there, there's not much out there. But it can definitely serve as a collection point for infections. So if you ever have a patient with pneumonia, especially if they're older, remember that because maybe that's just pneumonia, and okay, great, we treat that, but maybe there's something hiding behind that pneumonia that we're not tracking right away, so we want to make sure we're just aware of that. There are other signs of cancers, right? Changes in bowel bladder habits. So if normally you poop 1 or 2 times a day, and all of a sudden you're pooping 4 or 5 times a day, maybe that's a sign of a cancer, or vice versa. Maybe you go every day, and all of a sudden you're not going every day, or you're going every 2 or 3 days. Maybe you have some type of mass in your colon that's stopping that passage of stool. If you have unusual bleeding or discharge, so maybe you have some type of blood cancer and it's destroying your platelets, and so now you have no platelets, so you cut yourself, or you're having these nosebleeds because that minor trauma that normally would be stopped with platelets, you don't have those blood cells that you need those platelets to actually stop that. Changing wart or mole, so that's probably pretty typical. If you have somebody coming in and they have a mole and they're saying, hey, the thing's changing, that should kind of key you off to maybe there's a cancerous process going on, especially melanoma. Melanoma is a big one where that mole, if you have a rapidly changing mole, that should key you into saying this is some type of potentially legacy of the mole. And then just some more kind of visuals for you. I think it's kind of very useful information, especially for your patients when you see this. But if somebody has a lump or swelling, we talked about that. If they have lymphadenopathy and it's been there for a while and it's not painful, that should key you in. We talked about the bowel changes, cough, shortness of breath, or voice changes. So sometimes you can get cancer in your vocal cords, or that could be a cancer in your lungs. So a lot of things that our patients are going to present with, and they're going to come to you and expect you to know what these mean. You just don't want to blow them off, right? You just don't want to say this is normal, because if you do that and it's not normal, then they're going to come back 6 months from now, a year from now, and now that cancer has spread, and now it's kind of too late to do what we need to do for them. All right, so clinical example here. So picture yourself in the clinic. You're seeing this 46-year-old male, and he's coming in for a sore throat. He's got hoarseness for the past 6 weeks. He was seen in an urgent care, acute care clinic 3 weeks ago. They said, hey, you probably got a virus. Go home, take some medication, just rest up. He did that. He's not getting better, so now he's coming back to see you, right? You do your open QRST, you ask him all your review assistance questions, and he's not really having anything. He's not having any fevers, chills, night sweats, no reflux. You remember about the weight change, and you ask him about weight changes, and he's like, no, I'm staying the same weight. And you look back, and you see, okay, yeah, his weight's normal, nothing's changed. But then he tells you he smokes a pack of cigarettes per day. Now, we don't know how long he's been smoking, but maybe we can assume it's been quite a while, especially if he's 46. And he drinks a couple of glasses of wine every day, right? You look at his vital signs, they don't look too crazy, doesn't look too terrible. You do your physical exam and you start noticing that he has some lymphadenopathy in the submandibular lymph nodes. So the first thing I want to ask you guys, and if you don't know this, that's fine, but do you think it's normal to have hoarseness and a sore throat for 6 weeks? If it was some type of URI, some type of upper respiratory infection, maybe maybe at the most, maybe 2 weeks, but they should be getting better, right? This patient has had this for 6 weeks, and this thing is not improved at all. So based off what you know so far, what you have here, what are some worrisome history and physical exam findings that you see in this scenario? Lymphadenopathy? It's non-tender, okay. What about his history? Smoking, drinking, right? So now he's telling you he's doing some things, or he's exposed to some environmental influences that can potentially predispose him to developing cancer. So what are you going to do for the patient? What do you want to do for this patient? There's a lot of ways to treat this. I want to make sure I don't hear one thing. So what would you want to do for this patient? What's that? Okay. I don't want you to send this patient home and say, keep taking your medications and you'll be fine. Don't do that. If you ever get any type of inclination that your patient has something, if you get this thing in your head that says, this is not normal, work it up, work it up. Do whatever you have to do to work this up. If you don't know how to work this up, go talk to another PA that you work with, go talk to the doctor that you work with. But if you ever get this funny feeling in the back of your head that this is not normal, I need to do something more, do it. Don't say, oh, let's just give it a couple more weeks, because by that time, maybe it's too late and that cancer has spread. And so the worst thing that's going to happen to you is if you work something up, potentially, the worst thing that's going to happen is that you work this patient up and everything's fine. Maybe you feel silly, maybe you feel like, man, why did I do that? I don't know my stuff. Who cares? Who cares? Don't worry about that stuff, especially in the beginning. Don't worry about what other PAs think about you, what the docs think about you. They think, hey, you're ordering too many labs, you're ordering too many imaging. Who cares? Because that one time where you do work it up and you catch something, you just saved that patient's life. And hopefully that should make you feel good, right? So don't worry about that kind of stuff, because that used to get into my head. That used to get into my head like, why am I doing this? I don't know my stuff that well. And then I worked something up one time, or a lot of times, and I found that thing that was causing that patient's issue, and that patient was thankful. So just think about that. Don't blow your patients off. When you're in clinic and you're seeing 20 patients a day, it's going to be hard to remember that, right? But they're coming to you for help. And think about when you've been a patient. You've been a patient before, and maybe you've had good patient care, maybe you've had bad patient care. But always remember that person's coming to you for help, and if you blow them off, then potentially you're going to miss something like this. Cool? All right, guys, that's all I got for you guys. Any questions? All right.